us quite a lot of information that we will really enjoy to have shared to us as we learn. Before I begin, a few announcements for those who may not be aware. There is the Wi-Fi password, which is Paradise 2023. Tea has just ended. It was at the exhibition area. We'll be sharing more about the lunch. We have the exhibitors who please kindly patron their stands, get to know what they do, and ensure that you learn more from them. We have CFAO who will be coming up shortly. They are displaying their cars. Doctors have to drive nice, techy cars, except for the farmers like me who need pickups, but they said they do have some. There's some vehicles out there. Then there's just right outside the parking. The bathrooms are at the main convention area. You can pass through the right-hand side and you'll see an exit on that end. And then there is merchandise being sold by KMA. Do register at the registration desk. Ensure you support the association. And there is vouchers for lunch that will be issued as we exit on both exits. Register for the AMJ Gala. We are celebrating 100 years. Imagine, 100 years. It's an exciting moment, and we are really looking forward to wining and dining and having a good time together as we also network and get to know each other. So without further ado, we'll begin our session today. We have a great speaker coming up. This is Professor Peter Gishangi. He's the Deputy Vice Chancellor at the Technical University, Mombasa. I will not engage so far in terms of his profile, but he's speaking about something wonderful, One Health approach in health system strengthening, and we look forward to hearing from you. Welcome, Prof, to this session.
Thank you, Mugambi. Good morning, colleagues. I'm happy to share with you what I was requested to share with you. That is One Health approach in health system strengthening. Okay. Good. I'll try and do this in the context of the theme of the conference. Those are my letters. Today I'm the acting Vice Chancellor because my Vice Chancellor is away. So this is the outline of what I'm going to discuss, the One Health in the context of the theme, the facts about One Health system. I'll talk about what is being done, and I'll conclude. I've been given 10 minutes. I would have loved to have 45 minutes. I will try and fit what I have to say within those 10 minutes. I will not dwell here because you know the 6 building blocks of the health system and what the goals are, and we need to remind ourselves about that, because if you're looking at the health system, you can break it down into 3 purposes. One is to promote, restore, and maintain health, and therefore in the context of health system strengthening, then you're looking at strategies, responses, and activities which will all be geared to enable you to have a sustainable health in the context of the building blocks. And I will say a few words here, the origin of One Health system, and you know COVID-19 and the stories around COVID-19 in terms of the origin, but this was important because it elevated the need to look at One Health system, looking at 3 different elements, and here we are looking at humans, animals, and our ecosystem. And because of that, there was a panel which has been established, but to note that this is a multi-sectoral approach where we have Food and Agriculture Organization, World Health Organization, World Organization of Animal Health, as well as UNEP. And these groups then came up with One Health high-level expert panel. And this is important because it has elevated the concept of One Health to the fact that it needs to be operationalized. And this is what I'm going to be talking about at high level. It is important because those four institutions thought, how can they work together to achieve one common goal? And so there are several definitions. But important is you scan our literature, and I know a lot of us go to PubMed and you scan and ask for One Health, you have about 2,133 results. But if you took the same and looked for One Health system, you have about 41. But it's important for us who are interested in this subject matter to visit and look at how has it been applied. And therefore, World Health Organization defined One Health approach or system as an approach to designing, implementing programs, policies, registration, and I refer you to the registration of 2015, research in which multiple sectors communicate, work together to achieve better public health. So, of course, that is the lens of WHO. What about CDC, Center for Disease Control? And they looked at it as an approach which recognizes that health of people is closely connected to the health of animals and our shared environment. And indeed, that is what now everybody is looking at. So the One Health high-level expert panel then look at the same concept, and this is now the operational definition of One Health system, that it looks at an integrated, unifying approach that aims to sustainably balance and optimize the health of people, animals, and ecosystem. And I think since morning we have been hearing different pieces of these three elements here. And it's important for us as clinicians, and sometimes the shift of mindset from your success being one patient to your success being a group of people, and now your success is being required to think about animals and the ecosystem. And certainly you can look at that reference. But there are key underlying principles which are important as you're looking at One Health system. One is equity, which means sectors and disciplines are equal. Socio-political and multicultural parity, the doctrine that all human beings are equal. They have equal rights, and it's important to include different voices. Social equilibrium that seeks harmonious balance between humans, animal, and our environment. And anything you think as a doctor, those three elements come into play. And I think several elements have been mentioned here, but we now need to look at them not as piecemeal, but as one system. And that is going to make the difference, because the moment you think about infectious diseases, animals, and your environment, that is where the change is happening. We look at stewardship and responsibility. There's going to be requirement of resources to do these things. And unless you have that, then you may not be able to get where we want to do or to be. Multidisciplinarity and multi-sectoral interactions that will be important. This is to bring you to the attention that we have One Health joint plan of action. And that has detailed actions which needs to be taken to realize the One Health system. And I shall not go into details there, but it's important to note you'll be looking at data and using data for decision making among the pathways. And those are the important elements we need to consider: enhancing health capacities to strengthen health system, looking at reducing the risk from emerging and re-emerging pandemics, looking at controlling and eliminating zoonotic diseases, strengthening and assessment of management of food and safety and food safety, curbing the silent pandemic of antimicrobial resistance, and integrating environment in the One Health system. And this is an extract from World Bank, which looks at all these elements. And I think the take-home message here is One Health system is necessary foundation for human security. And indeed, if all those things are going to happen, then we'll be a secure human race. And so to actualize this, CDC sees three components: coordination, communicating, and collaboration. And they all address the human interaction with the environment, and we need that to be able to achieve a sustainable ecosystem. But the One Health high-level panel of experts has added an important piece to the equation, and this is where I come in as an educator: capacity building. And I think the previous speakers have mentioned elements of it. You need capacity to be able to do some of those things. Some of the trainings you have had is in silos, but you need to integrate it, and you need that one-sector component, and therefore there will be an element of training required to be able to achieve these things. Climate change, the biggest health threat facing humanity. And we had that in the opening ceremony yesterday, and there are elements which I want to just quickly mention. 1.5 degrees Celsius rise is not acceptable, but we also had that is the most vulnerable who contribute risk who suffer from it. And there are many things which are happening. Certainly we have increased the number of diseases from all the challenges happening. We have air pollution, we have environment, France, we have displacement of people. It is important that we look at all these things in the context of where we provide our services. There are, of course, climate-sensitive health risks, which we need to do more research on. And this brings, in a nutshell, all the things I've said, where you look at the vulnerability, you look at the health system, you look at what factors, demographic and otherwise, and you can see the elements which are important for us to consider. And important, as we do all these things, let's make sure that we measure the things, looking at fairness, access in financing, quality, responsiveness, efficiency, and resilience. Certainly, as you're looking, we need to make sure that our health systems are climate resilient. There are many things we can achieve through this process. In conclusion, I think it's time for us, and I am happy that we are here as a medical practitioners and medical fraternity, to think of how do we put all these pieces together. We need to be the agents of change. We need to reach to other systems. We need to have efforts to break down our components, which are many in silos. We need to refocus our education system. We truly need to have one comprehensive approach to these things so that it becomes part of your process. And finally, where I sit, I do a lot of work in terms of data, and we need data for decision making. And therefore, the need to have more research activities in this agenda. I thank you for listening to me.
Thank you very much, Prof, for that outline on One Health. Thank you very much, Prof, for that outline of One Health. We truly look forward to embracing it within our practices and within our workplaces. I would like to ask that you keep your questions. We will engage with questions at the end of this overall session. And our rapporteurs, please stand up. Let me introduce you. There's two rapporteurs at the front here, and they will be giving you time for the two at the front here will be allocating you time and reminding you that time is passing. So for the speakers who are coming up, focus and check out on those two. Thank you, rapporteur. So I want to welcome Mr. John. He is representing Dr. Ayepo from UNFPA, and will be speaking about the impact of climate change on sexual, reproductive health rights, and gender-based violence. So he is online, and he'll be the next speaker.
Good morning, colleagues. I hope you can see the presentation. Hello, can you hear me? Okay, thank you. On behalf of UNFPA and on behalf of my colleagues, Dr. Oyeyipo and Dr. Okoro, it's our pleasure to make this presentation at a very esteemed conference. This is on climate change, which is critical to all development perspectives that we embrace today. So as it has been stated, our presentation is on the impact of climate change on SRH, Sexual and Reproductive Health Rights and Gender-Based Violence. Climate change, colleagues, is a major threat to the vision of human-centered sustainable development as outlined in the International Conference on Population and Development Program of Action. This was in 1994 in Cairo, and it's the document that frames UNFPA's holistic mandate around matters sexual and reproductive health, gender-based violence, the focus on the youth and the population, and data. Therefore, as early as in the 90s, there was recognition among development actors across the world that climate change underlines much of the progress that we desire to achieve around the issues sexual and reproductive health and protection of rights with regard to gender-based violence. So climate change is a multiplier of existing health vulnerabilities and gender inequalities, and will make the transformative results more difficult to achieve and sustain over the decade of action, this particular decade. When we talk of transformative results, we are talking of zero preventable maternal deaths, zero unmet need for family planning, and zero gender-based violence and other harmful practices. UNFPA considers those as the three transformative results. And climate change is progressively emerging as a major barrier to realizing those transformative results. That explains our investment in understanding the linkage between climate change and sexual and reproductive health and gender-based violence. I have briefly switched on my camera so that colleagues can also see the face behind the presentation, but this will not be for long because of connectivity. But I think, colleagues, you've seen the face, so I can now switch off the camera so that my voice is clear and there are no interruptions. When we look at the literature that exists on the impact of climate change on maternal health, the direct impact is such that heat worsens maternal and neonatal health outcomes. An increase of 1 degree Celsius in the week before delivery corresponds with a 6% greater likelihood of stillbirth. This is literature from the Lancet, quite an authoritative journal. Global heating impacts the patterns of vector-borne diseases such as malaria, with negative outcomes such as maternal illness and low birth weight. As WHO, climate change again worsens global inequity in maternal nutrition, the Lancet 2020. So again, you can see these clinical aspects and aspects of inequity that affect maternal health. The indirect impact is such that climate-related emergencies cause major disruptions in access to health services and life-saving commodities, including contraception. Colleagues, we are familiar with the 3 delays model. Climate change can affect, especially the second aspect of delay, accessing health facilities. And even the third aspect of delay are receiving quality services. Because, for instance, if we've had flooding and health facilities have either been marooned or they have been swept away, then access to the facility in itself is a challenge. If communities have been cut off, expectant women and even the support system that exists may not access the health facilities. And sometimes even when you access the health facilities, the supplies and the personnel to provide the services could also be affected by the barriers that the climate change related disaster has caused, and so they are not available to provide those services. Increased poverty and food insecurity driven by climate-related loss of livelihoods and affect maternal health, again the Lancet in 2021. On climate change and gender, research again is indicating that climate change increases the risk of violence against women. That is the United Nations Conference on Climate Change. And GBV, child, early and forced marriages and trafficking have been seen to increase following disasters and extreme weather events. We've just had a severe drought in this country, and some of the assessments that we've taken showed that there has been a spike in female genital mutilation, in child marriage, and other social cultural practices that negatively affect protection of rights. So the pressure on families due to floods, droughts, disasters, and other climate impacts can also result in early forced and child marriage. Climate-related events may also enable situations where people are at greater risk of contracting HIV. A gender rapid assessment that we undertook last year in collaboration with some of our partners like the International Rescue Committee highlighted some of these aspects. For example, in counties like Turkana, in counties like Kajiado, we are told that men are going away for long periods as they look for pasture for their livestock. When they come back and interact sexually with the women, cases of STIs are being reported. So you can see how, again, indirectly and indirectly, climate change is a factor to highlight when you are looking at maternal health and gender issues. But despite this, we recognize that the International Conference on Population and Development Issues are not broadly covered in climate negotiations. Gender and health, strong in climate negotiations, but with significant gaps related to ICPD issues. And this is lack of attention to maternal neonatal health, human rights and sexual reproductive health rights, gender-based violence, and other key gender-related sectors. So when we look at how climate negotiations, the architecture of climate negotiations is progressing globally, these issues are not well highlighted. The International Panel on Climate Change, a special report noted that the likelihood that both climate change and gender-blind climate change interventions could worsen gender inequality. This is acknowledged at that very, very high level. Again, something that was emphasized at last year's conference on climate change in Egypt, the COP27. The UN Commission on Population and Development has emphasized that climate change. So UNFPA are taking note of the fact that climate change issues are not being featured Agenda and SRA issues are not being featured in climate change-related negotiations. Commissioned a study on nationally determined contributions. The nationally determined contribution, NDC document, is a document that countries developed indicating or binding themselves to take or pursue specific measures aimed at mitigating effects of climate change. Kenya's document, the latest one is up to 2020, and I know the revisions, they're ongoing. So UNFPA commissioned an assessment of 50 nationally determined contributions documents. And some of the findings are what we note here. The study focused on content analysis for all reference to sexual and reproductive health rights, gender health, population dynamics, human rights, and participation and vulnerable groups. It looked at 50 countries initially in the East and Southern African region, but also extended to other 27 countries. All 50 made some reference to health, but 8 out of the 50 made reference to specific vulnerable groups, 16 out of 38 on women, but 6 out of the 50 NDCs made reference to gender, 25 out of the 50 made some reference to population dynamics as a challenge, and 6 out of 50 NDCs contain direct sexual and reproductive health references, maternal and indeed even HIV. So you can see, for example, when you are talking of maternal health, family planning, GBV and HIV, only 6 of the nationally determined contribution documents made reference to these critical areas. And as we've said, this is the main policy document that outlines or carries the entire architecture of how governments are going to address effects of climate change. So if only 6 out of 50 countries, and even the Kenyan document is not among the 6 countries, because we've looked at it and seen quite some glaring gaps. So you realize how much advocacy is needed around these issues. Our findings show that sexual and reproductive health in the NDCs, for example, in the Solomon Islands, women have poor access to health and family planning services in the rural areas. People living with HIV. In Eswatini, the health sector will be affected by climate change impacts, with groups such as households with the members living with HIV expected to be particularly vulnerable. 26% of the adult population is currently living with HIV in that country. So a summary of the key findings is these 6 out of the 50, this included references to aspects of SRA, but there is scope for greater and more meaningful inclusion of the full range of sexual and reproductive health rights. Gender-based violence presents a key intersection of sexual and reproductive health rights and climate change that should be addressed in climate change adaptation policy. Again, the inclusion of sexual and reproductive health rights and population dynamics in climate policy must be human rights-based and reflect the ICPD program of action. As I said, this is the main document, the ICPD program of action that frames UNFPA's work globally, but is also the document that informed the ICPD at 25 summit that was convened in this country in 2019, and Kenya has made a range of commitments that contribute towards our realization of the Sustainable Development Goals. Realization of sexual and reproductive health helps to build resilience and adaptive capacity for climate change while reducing inequality and enabling justice. Having looked at these issues, UNFPA has proposed a framework for climate change resilience and the promise of the ICPD at 25. That was the Nairobi summit in 2019. What are the key components of this framework? Issues that should be focused on if we are to realize a positive interaction between climate change as we undertake climate action and sexual and reproductive health, gender-based violence. One is that we should focus on health-empowered populations, including women, girls, and young people. what are the needs of women, what are the needs of girls, what are the needs of young people, and how do we sustain their health status across the nexus, humanitarian development and peace. What are some of the measures that we should take to ensure that is done? Climate resilient systems, health protection and education. Our health systems should be climate resilient. Again, what type of interventions are necessary for this? And there are also aim to realize reduced risk, better preparedness, strong emergency response, like what we undertake in this country, minimum initial service package for reproductive health assessments, pre-positioning of inter-agency reproductive health kits and so forth, so that the level of preparedness in the event that there is an emergency is adequate enough. And then finally, population health and gender data on vulnerability, impact and resilience. This is again an intervention that we should undertake. There are details on how each of these components can be broken down, but because of time, permit me, colleagues, not to go into those details. Overall, we are looking at how policies, programs, and partnerships and financing can help us to strongly integrate SRH and GBV into climate action. Thank you for listening to me. It was a pleasure making this presentation on behalf of my colleagues, Dr. Aoyepo and Dr. Okoro. Thank you.
Thank you very much, Mr. John Wafula, for that presentation. We truly appreciate the insights that you've given us in terms of climate change, sexual, reproductive health, and gender-based violence. We will ask you to please hang on online. We'll have questions for you. I know you needed some time forward so that we can be able to engage further as we move on. So next we have our partners, Apollo Hospital Group. We are truly appreciative of having you as one of our key stakeholders in terms of continuous medical education and also capacity building of our members locally and internationally. And we are glad to have three key speakers actually. Vinat Aurora, who's a senior interventional cardiologist. She was the first female to be trained in, she was the first female trained in interventional cardiology. Then we have Nivette Siraya, a spine surgeon from Apollo Hospital. And we have Dr. Rihat Bahat, a urologist and kidney specialist. I'm sorry if I mispronounced your name. You will correct that. And we are so happy to have you today. So we'll start off with a video that will demonstrate a few of the works that they are doing, and then we'll have them speak. We give you 30 minutes and 10 minutes video.
To be performed in the office setting under local anesthesia.
Very good morning to all of you. My name is Mr. Navneet Saraya. I'm a consultant spine surgeon at Apollo Hospitals in India. The very first thing that I have to say is that I am extremely grateful for you all giving me the opportunity to come amidst you and give us the time to speak and your time to listen to us. We at Apollo Hospitals are grateful and delighted to be a partner with the KMA for such a long time, and have been providing our services to the Kenyan community, and have received so much love and appreciation from you that every time there is an opportunity we latch onto it to be a part of this community and provide our services to the best possible standard that we can, and be a partner in this global friendship that is very important going forward in the future. Now, I'm deviating a little bit from the theme of the session, but as a spine surgeon, and as the speakers before me have already suggested, that every one of us has a responsibility to think about the climate. And I firmly believe that big actions, big decisions, big changes seldom ever bring changes on the ground. It's the small changes which, if continued to happen over the long period of time, they accrue to big results in the future. So if each of us has a little bit of effort in their daily life to think about the climate, then that will compound eventually to the big changes that we're aiming to achieve by all of these projects that we have undertaken, One Health, for example. And from my point of view, I'm a spine surgeon. I operate on people, make their spines better. And when I think about it, how can I be a part of this changing work culture? And the one thing that comes into my mind, and the one word, it's a very simple thing, is efficiency. It's a very simple word, efficiency. What is efficiency? Efficiency is getting better at what we do each day. And efficiency itself translates into saving, into climate change, into negative carbon footprint, everything. Everything boils down to efficiency in my own practice. Let me translate into surgical practice then. Give you a very simple example. Somebody with a disc prolapse needs surgery. 20 years ago, it used to take a 10 centimeter incision, big bone cutting, 3.5 hour surgery, 4 days in the hospital, and then 10 to 20 days rehabilitation for them to get back onto the street to do their work. Currently, this is where the efficiency comes in. We do an endoscopic surgery, which takes 45 minutes to do, little or very minimal anesthesia involved, little or minimal patient morbidity, and the patient goes home the same day walking, right? So compared to that patient 20 years ago, have I saved energy? Have I saved waste? Have I saved patient morbidity? Because I have put that patient back into the community 20 days earlier, have I made him more productive? Right? So this is where efficiency translates into global climate change. This is where a mindset and technology can come together to increase our output, increase our efficiency, our work ethic, to then reduce our waste and increase the little things that make us a better society. So that is my spiel. Let me go to the presentation about what we do and how changes in spine surgery over the last decade or so have made us more efficient, which is the root message from my talk. Next slide, please. So we are Apollo Hospitals. We are a chain in India and overseas, and we are one of the largest healthcare chains all over South Asia. Next slide, please. Right, sorry. That's where we are. I'm based in Ahmedabad, lush green surroundings, and that is me. I trained in the UK and have been working at the Apollo for the last year and a half. So I'm going to transport you back to your medical school for a little bit, just to lay the foundation, and then I'll transport you back to the current timing. Oops. So let me talk a little bit about the spine first, just to refresh our knowledge, because that is where I'm going to build on what we are doing now, which was totally different to what it was 10 years ago. I'm sorry about this, right? I think the technology is playing a game with me, right? I thought technology was supposed to help, but yeah, it doesn't happen all the time, it doesn't work all the time, right? But when it works, it's beautiful. Right. So 31 vertebrae, 23 discs is what all we have and is what all we have to work with. Next, please. What we have started, what is advance? Advance is not only technology, advance is the thinking. The advance comes with thinking first, and then the technology comes in. So we have now started to think more about the curves of the spine than what we traditionally were thinking about the bones and the discs separately. So we're looking at cervical curves, which is the most mobile, lumbar curves, which is the most mobile, and it's those curves that has led us to devise the new technological advancements that we see nowadays. Next one, please. Why the curves are important? Because when we were quadruped, we had a very flat curve. When we are biped now, the more curvatured spine is what we function on. It is the foundation of the human mobility. Next one. There are various functions of the spine. We won't go into that. The most important one of them is the protection of the spinal cord. And that is another thing which has led us to think more about the advances that we can make to protect the spinal cord so that the function can be restored. We think of the spine as a unit, 2 vertebrae interspersed with the disc, and all the forces that go through the disc and the bones in that particular unit is all that leads to all the pathologies that happen to the spine. The disc prolapse, the cancers, the infections, the deformities, scoliosis, everything that happens has a root in that little unit, 2 vertebrae and the disc. Next, please. What we don't think about, what we don't see, what we don't imagine are the muscles. We have to think of our spine as a tent with the guy ropes holding the mid-pole. The mid-pole wouldn't stand if the guy ropes aren't strong. We have muscles in the front and the muscles at the back. So this is the second point of the intervention which people don't think about, is how to get those muscles to function better to make the whole spine as a unit, keep the tent upright. So that is another point of thinking which has changed in the last 5 years. We won't go through the symptoms of spine problems. We have back, neck pain, sciatica, which is nerve pain. When you have this problem in the neck, you get arm pain, you get weakness, as you can see, bowel or bladder disturbance, and sensory problems. These are all the symptoms of spine problems that can lead to us. The important ones for us to look for, and this is again where the efficiency comes through. How to diagnose a problem and get that patient to the correct professional in the shortest possible time so that they don't have to go through 4 or 5 different specialists before they get the right advice, before they get the right treatment. That is the efficiency. So if we have the knowledge of the red flags, we know where to send that patient so that he or she doesn't suffer and gets the right treatment at the shortest possible time and is back into the community being productive. Signs. If you have pain in the neck, arms, legs, paraplegia, bowel or bladder dysfunction, loss of sexual function, loss of balance. These are the really important signs. If you pick up, get a spine surgeon. What are time-critical symptoms and signs? If you have pain that is bilateral, incontinence or retention of urine or feces, if the back pain is associated with fever, if you have night pain, if you have any weakness, any loss of balance or paralysis, that is an emergency. Please rush, get a spine or a neurosurgeon input and get that patient seen, right? Again, efficiency right from the bottom, grassroots up to the hospital is the key to be seen here. Who to seek spine opinion from? Think of the spinal cord. If the problem is within the spinal cord, it's a neurosurgeon. If the problem is outside the spinal cord, think of a spine surgeon. That is again where the correct reference makes the biggest difference in terms of the correct treatment at the right time. Timing, right. So, when you are assessing the patient and you feel that there is any risk to the nerves of the spinal cord, that's an emergency. Get the patient rushed up to the hospital. Barring that, if you can live without medicine with the pain, please carry on. We don't want to operate till it's the last resort, okay? Try every non-surgical method for 3 months. If it doesn't work for 3 months, move on quickly. You're wasting time, okay? If nothing works, don't delay. Because as you delay, the spine problem inevitably keeps getting worse. If it keeps getting worse, it's more difficult to treat later on. It is more expensive to treat later on. It will cost more time in rehabilitation if the correct procedure is not done at the right time. So the 3-month principle is quite a standard in spine surgery. Try something for 3 months. If it doesn't work, move to the next step. If it doesn't work, move to the next step. Okay? Living in pain is poor quality of life. We have to consider the cost of that. If a patient has lived for 2 years with back pain, what is the cost of that quality of life that the patient has suffered? Not in terms of money, in terms of social interactions, in terms of mental health, in terms of health of the family, etc. So, this is where the new age of spine surgery comes in. If the right person comes to the right doctor at the right time with the right facilities, we can get them back into community at the quickest as possible compared to what it was 10 years ago, right? We have the facility of navigation, which makes our screw placement extremely accurate, reduces the complication rate by about 5%. Microscopic surgery with 10 times magnification is the gold standard for any disc surgery currently. Endoscopic surgery, as I said, I can get the patient out of the hospital on the same day, pain-free, walking on his feet, and go to their work next day with endoscopic surgery. Modern implants that we have, they are adapted to the bone that is weak for osteoporotic people, right? I have a few examples, so I won't talk a lot. Let the video do the talking. Can you please play the one on the right, please? So this lady fell. Can you stop the previous one, please? Can we have one at a time? No. Please go backwards. Yes. Can you play one at a time? Thank you. No. That one. Yes. Can you click on each? Right. Okay, there we are. So there we are. So this is a 67-year-old male, and if you look at the vertebra above, it's completely crushed, and it is causing crush of the spinal cord. This patient came paralyzed below the waist. He has multi-system problems. We fixed him. Anterior and posterior decompression was done with a small approach, 3.5-hour surgery only, to put 10 screws, decompress the spine. This is him 3 weeks after surgery. This is him 2 months after surgery. And this is him 4 months after surgery, able to climb the stairs. Quality of life is what we are giving the patient. This patient was given 6 months to survive with amyloidosis and multi-system involvement. For those, at least 3 months, he'll be on his feet, enjoying his life as much as he possibly can. Right? This is what we can provide with the modern implants that we provide to our patients. Can we play the next video, please? This is a young lady, a 25-year-old, who fell and broke her spine. And she was very unstable. For 2 weeks, she couldn't get out of bed. We did a minimally invasive surgery, very small cuts, which you'll see later on, percutaneous stabilization. And we were able to correct the fracture and deformity just by those small cuts that we made to introduce those wires and screws. It preserves the bone versus kyphoplasty. It is more efficient than the other alternative procedure that we used to perform before. We have restored the balance of this 25-year-old girl who's got at least 25 more years of a healthy, functioning life in front of her. These are the cuts that we made. These are the 6 screws that we entered through very small cuts. The total operating time was only 1 hour and 30 minutes. She was out of the hospital the next day with these small cuts. She's 2 weeks now. She's on her feet. She's pain-free. For 2 weeks, she was not able to get out of bed. She was out of hospital the next day and walking pain-free at 2 weeks with just these small cuts. So, again, I will continue to emphasize efficiency here. continue to emphasize the reduction in morbidity and quick recovery, quickly back to the society. Right, next one. Okay, next slide, please. No, just flip to the next slide, please. Thank you. Yes, that's right. I just have a footnote on prevention, and prevention is always better than cure, always saves money. What I wanted to just have a look at is that MRI scan on the left-hand side, and that is the thing that I wanted to take out from here is water. How important is water in our life? On the left is an MRI scan early in the morning. Red is the amount of water we have in our discs when we wake up in the morning. The hospital got 200 volunteers got an MRI scan in the morning for all of them. They went about their work. They came back in the evening and had another MRI scan done. Just their routine work. And look at the amount of water that they have at the end of the day. It is significantly reduced towards the end of the day, right? That is what we are doing to our spine as we are sitting here listening to me. You are reducing the water in your discs each and every minute. So please focus on water. If you do nothing else, if you don't do exercise, if you don't focus on your spine, if you don't have a good posture, so long as you are putting water into your body almost every hour, you will prevent those discs from drying out and prevent problems in the future. So that's just one footnote that I have to say about prevention here. Okay, next one please. Thank you, and please feel free to engage with us at our services. We are a JCI accredited organization for the last 3 consecutive terms. Our standards speak for ourselves, our patients speak for ourselves, and as I said, it's always a delight to come to Kenya and mix with the wonderful people that we have made friends with here, and we continue to be a part of this community, providing solutions, providing healthy alternatives and operative solutions. Thank you very much. Thank you for your time.
First of all, I would like to express my gratitude towards Kenya Medical Association to giving me an opportunity to share some knowledge with you, and obviously I congratulate to all of you to conducting such a wonderful conference. So I also work at the same hospital, and my colleague has already told you something about the hospital, that where it is. We are situated in Ahmedabad, which is in the western part of India, in the state of Gujarat. So, as I am a uro-oncologist and the robotic surgeon. Next slide, please. Here is how our hospital looks like. Yeah, so as having a uro-oncologist and robotic surgeon, again I have to deviate it something to a different topic. But you will find a connection in all these topics, that the technology and innovation, how they have changed our life, and the ultimate goal is to decrease the morbidity, increase efficiency, and that ultimately counts to betterment of the society in general. Next slide, please. So robotic, definitely a much needed innovation in our healthcare, and thanks to the equipment which we got nearly 2 decades ago, but it was popularized in last 7 to 8 years only. So the credit goes to the famous Leonardo da Vinci in 1495 to just give an idea about this, but we wasted nearly 5 decades. And in 20th century only, when the people worked on the robot, and in the late 20th, we finally came up with an idea, and now we are using the robotic system in our medical practice in different specialties. Next slide, please. So I will talk about the robot in urological practice only. So the word itself says a lot. The robot word came from robota, which is a Czech word which means forced labor. So obviously the robot is machine, and the robot itself can't do anything unless the general perception that in some scenario that if the robot can do something, then there might be chances of grave consequences, which is fortunately not the case. There are a couple of robotic systems in the market, but Da Vinci is the most predominated system, and it got US FDA approval in 2000, and the rest of the system like the CMR, which is the Cambridge based, or Hugo, also called as Medtronics, they came into pictures in last 2 years only, and obviously they need randomized controlled trials, but the Da Vinci has already proved this. So we are also using the Da Vinci system, which is the Xi topmost version. Next slide, please. So as you can see the picture, it has three basic components. On the leftmost corner, it is the patient card, which has 4 arms. The center one is the vision card that includes integrated energy sources, and the rightmost one is the surgical console, which has 3D magnification, high definition camera, and the surgeon's control over the instrument, or in fact the whole machine. Right. Next slide. So the only permanent thing in life is change, and the Da Vinci has also followed this principle. So in last 20 years, there are a lot of changes in the Da Vinci system. So in Xi system, it built with the high definition, 3-dimensional magnification, with the stereotactic vision, depth perception, more precision, inbuilt intraoperative ultrasound scan, and couple of other technology like Firefly, which is nothing other than a dye test, so that we can identify for the tumor cells that after the surgery, at the same time when the patient is under anesthesia, that the tumor is out or not, because the tumor cell magnify. So definitely, this was also a much needed innovation. Next slide, please. So the advantages of robotics. So as I said that it has a combination of open and laparoscopic approach. Okay, I will stick to time. Looks like time flies. So they just mentioned about the less than 5 minutes only. Anyways, so the advantages is 3-dimension and the stereotactic vision. So it has an ideal combination of open and laparoscopic approach, but the added advantage of precision and magnification, which ultimately improves in the patient's outcome. Next slide. So some says that the robot is more costly, and if we go for the cost benefit analysis, the robot is far behind in that, but that's not the case, because we have to see patient in total. In terms of benefits, there is early recovery. For example, if you talk about the prostate cancer patients, we can discharge him on the very next day. We usually discharge prostate cancer patient after robotic surgery in 48 hours, or sometimes in very next day. In fact, he is mobile on the same day of the surgery. He can eat and drink, and obviously that ultimately benefits in the morbidity, patient's productivity, and the complication rate is also less. So blood transfusion rate is minimal. So if you talk about for a certain duration like 4 weeks to 3 months time, ultimately it improves productivity of the patient, less utilization of hospital resources, less hospital visits, because patients usually don't have much complications. In the robotic prostate surgery, mainly it's the urinary incontinence, but thanks to robot, it's a game changer. It's not, definitely not say overstatement if I say it's a game changer. It has improvised the technique in such a way that now prostate cancer patients can be managed in a much effective way. Next slide, please. Next slide. So in the urology, the robot can be used in all the platforms where the laparoscopy can be used, but the kidney transplant is an added advantage, especially in the kidney recipient, where we can't even think about use of laparoscopic. So robotic can also be used in that scenario. In the prostate cancer, the debate is already over. The robot is the only technique which has to be used if available. In the partial nephrectomy, again, the same statement given by all guidelines, whether it's European or Americans. In the rest of the system, cystectomy and other, yes, the robot can also be used. So in prostate cancer patients, there is basically a trifecta, which means that oncological safety, the second is urinary incontinence, means early recovery from the urinary incontinence, and preservation of erectile function, which can be done by this approach only. I will show you a short video of that. Do you mind to play it? The time pilot. So this is our 69. Last slide, please. Just play it. So he is a 69-year-old patient having a localized prostate cancer. It was T2C and 0. T2C means that the disease was localized to prostate only and no lymph nodes, and PET scan showed there was no mets. He was a sexually active guy with the performance status 0. So I had a discussion with him and decided to go for the robotic radical prostatectomy and bilateral pelvic lymph node dissection. So you can see that there are 3 arms visible and one dissection that is my assistant is holding. On the very left side, the arm called as fenestrated bipolar. We all talking about technology, and technology is at the moment not helping us. So is the time over? Are they following you or me? Okay. Okay, so not this one. No, this is for the robotic partial nephrectomy. So the other video. Don't worry, I will play only one. Yeah. So obviously it's an edited video. Make this video suitable for the conference, but I'm sure that you can feel the magnification and the precision in this video thanks to robot only. So that's the prostate where we are working in. That's the space of Ritgius, and that's the lymph node over the prostate which we are removing. So we are using less energy because prostate is surrounded by neurovascular bundle, and so that's the area where the endopelvic fascia lies. So we are on the lateral side of the prostate. On the right side, that's the prostate, and on the left side, that's the levator fascia. So we are using only the sharp and the cold blunt dissection. So not much energy using. So we have to do that dissection on both sides to release the prostate and preserve the neurovascular bundle as well. And obviously it's a cancer surgery, so the cancer cell should not remain there. So this dissection should be like this, that you have to remove the prostate only, but minimal trauma to the surrounding tissues. So you can see that the prostate is being released from the surrounding tissues. And after that, so we are moving the Foley's catheter, urethral catheter, to identify the bladder neck, which is the area where the bladder joins the prostate. And from there we do dissection onto the anterior bladder neck, go inside, and you will soon see the Foley's catheter. Here it is. And now we will go inside to do a dissection on the posterior bladder neck. Ureteric orifices are far proximal, so obviously there is no risk. So once we go down, we will saw the other structure, which is vas deferens and seminal vesicles. And obviously we have to take these structures along with the prostate. So these shining structures are none other than the vas deferens, and the other structure related to this is seminal vesicle. So we have to control the vascular pedicles which are on the lateral side. So we can use little bit energy only, but not much. And obviously, as I said, that the blood transfusion rate is minimal with the robotic approach. The credit goes to magnification. And the other thing is, you can see the arms. The arms are highly mobile, means that in our normal hand, we can move into 4 direction only, and that's also a limited movement. So that's the posterior dissection. We are separating the bladder from the rectum. So I was talking about the arms movement. So they can move like 360 degree. So especially in the prostate, which is in the pelvic area. Okay, so just fast forward it. So that's the neurovascular, that's the lymph node dissection. That's the external iliac vessels. We have to remove the lymph nodes over the external iliac vessel and the obturator vessels. And these vessels should remain naked after the surgery, which means that you have done a good dissection. Fast forward it. Just go to the urethra. Yeah. So now we are doing the urethral anastomosis, uretrovesical anastomosis, and that's the key part. So just focus on the 12 o'clock position. That's the intra-abdominal length of the urethra. So, and that's the key part to maintain urine continence, for early recovery of the urine continence. So you can see that it's nearly more than 1 centimeter, although it's magnified, but still it's more than 1 centimeter. So it's a watertight anastomosis done with the absorbable suture, which has a bidirectional needle, and we fill the bladder with 120 ml at the end, and see, definitely there is no leak. So go to other slide. Well, there are a couple more slides. Okay, so apart from the prostate, yes, it can be done in other laparoscopic surgeries, but the efficacy has already proven in the urological cancer surgeries like bladder, kidney, prostate, retroperitoneal lymph node dissections in testicular cancer. Next slide, please. So I was talking about the arm movements. You can see that robotic arms can move in any direction. It's a 360 degree movement. So that's the reason that with the robotic approach, you have fantastic results. Next slide, please. Next slide. So for the pyeloplasty, which means that there is an obstruction between the kidney and the tube that connects the kidney to the bladder called ureter. And if it's a failed approach, means that the patient has already undergone 1 surgery, and if he needs 2nd surgery because of the failed, then definitely robot has a fantastic role. You can go for the first time only, but at the first time, results are fantastic, but in compared to laparoscopic, definitely there are still studies required to prove efficacy. So that's a picture that's showing CT scan showing the changes in the pre and post. The second CT scan was done 3 months after robotic pyeloplasty. Next slide. Next slide. So one last slide about the prostate biopsy. So we are doing the transperineal template biopsy as well. We are one of the few centers in world that are doing transperineal template biopsy. You know, for the high PSA patients, they need biopsy, and obviously transrectal biopsy is done almost everywhere, which is basic violation of surgical principles, that we are going from aseptic field, septic field to aseptic, means we are inoculating rectal bacteria to prostate. So European, next slide. European and American has already said that if possible, go for the transperineal biopsy to reduce the risk of sepsis and better identification of prostate cancer, because in certain area, especially the apical region, we can miss the cancer. So if we compare transrectal and transperineal, there are 10 to 20% chances of missing cancer in transrectal biopsy. So if possible, definitely should go for transperineal biopsy. And that also can be done under local anesthesia, although it's take 10 minutes more than the transrectal biopsy, and obviously, as I said, that it's safe. Next slide. Yeah. Next slide. Because time is over. Okay. Okay, thank you very much. And obviously, that's the pictures of our hospital, smart rooms at the way we work. It's nearly 400 bedded hospitals. And obviously, we are here to continue. Thank you very much.
Thank you very much to Apollo Hospital. 3 things I have learned from this session: technology, efficiency, and that's equals to climate mitigation. And you are doing a fantastic job. We hope you will hold on till the end of the session when we carry out the Q&A session. Please do hang on. So our next session speaker is Dr. Stephen Motiso. Dr. Stephen Motiso is a medical doctor and NCD epidemiologist. He leads renal programs in the division of NCD at the MOH. He's also leading the NCD monitoring and evaluation, and he's the Secretary Research Monitoring and Evaluation Technical Working Group at the MOH. He's Secretary NCD Poverty Commission of the Lancet Kenya chapter, and he's doing a wonderful job. We at the county can attest the work that Motiso is doing in terms of ensuring we have electronic medical records for monitoring NCDs within our counties. So he'll be talking about evaluating the impact of electronic medical record systems in improving the care process, treatment outcome, and data quality in hypertensive clinics in 2 counties. That's for 2021 and 2022. Welcome, Dr. Motiso.
Thank you very much. Good afternoon, everyone. I know this presentation is just before lunch, and that usually is a very dangerous time, so I'll try and keep it brief. I don't think I have any conflicts of interest to declare except for 2. One is I went to high school with the president. Fortunately, it was not Alliance. Secondly is I really am a very young member of KMA. I think I fall into the under 40 group. I don't know how popular that is, but we shall try and work with that. So maybe just before we get into the presentation, I'll try and be brief. Non-communicable diseases are becoming a very interesting sphere. We are talking about 50% of hospital admissions and 41% of deaths in our country right now attributable to NCDs. And I think that statistic is on the rise. Most of the presentations we've had today actually are linked one way or another to some kind of NCD, including the last one. So I think our doctors from Apollo showed us a video of a patient who had a fall down a series of stairs. Did not tell us why the patient had a fall. It's possibly a stroke, possibly something along those lines. Cancers, every one of us is touching onto cancers nowadays. We're looking at increasing prevalence of hypertension, diabetes, sickle cell for the children. I know I have to touch the heart of Prof as he's close by us here. So we were trying to look at whether using tech can help us to get better outcomes for patients in the NCD field. And so the title of this presentation was to evaluate the impact of an EMR, which is an electronic medical record system, in improving the care process, the treatment outcomes, and data quality in hypertensive clinics in 2 counties. So next slide, please. So a quarter of our population, which is about 25%, is noted to have elevated blood pressure. So that stands at about 12.5 million Kenyans. Of this, only 8% are on care, and only 4% actually get optimum control. And the question that begs is why? Fragmented care systems. Almost every other hospital does have some kind of an EMR. These EMRs do not talk to each other. We have high loss to follow-up rates. Patients move, and when they move, they open up new files, they open up new frontiers. We don't have their previous data. We also have inadequate data to evaluate our care and control programs. This happens to be the case for most NCD programs. Of late, I think we have a registry for cancer, but what happens to the patients who are on follow-up for dialysis? We have no central registry for them. I know Prof. Mwanda is here. He has dealt with quite a bit of hematological conditions. Do we have central registries? This begs the question. Once in a while. Do we have enough data? So for hypertension, unfortunately, no. Next slide, please. So we wanted to look at this EMR and see if it improves some data areas. One of them is climate change. And climate change is starting to touch onto NCDs in several sort of aspects. If you look at just the basic modifiable risk factors, number one, we are living in an era where toxicants are coming up left, right, and center. And these, some of them are carcinogenic. I was actually quite intrigued that we do have very nice cars outside from CFAO. Has anyone asked, aside from the engine capacity, whether they are turbocharged or not, what their emission ratings are? I leave that to the car enthusiasts. Food insecurity. We do know that we've had a drought. It's been quite tough for us. Unhealthy diets, cornerstone of obesity, risk factor. How about our housing and our environments? I think Tosif Dean spoke a little bit towards the issues of green spaces. Our kids nowadays don't have green spaces. We live in high-rise apartments. There's just lifts and playstations, tablets. This kind of spacing, does it allow us to play all day, all evening like kids do in the past or used to do in the past? Of course, when we talk about air pollution and chronic obstructive pulmonary diseases, we still have quite a bit in this space. Next slide, please. So when we're looking at this evaluation of the electronic versus paper-based systems, we wanted to look at, okay, fine, does it improve on a care process? So does this mean a patient's registered better? Do you have all their biodata? Do you know where they live? We wanted to look at things like, in the process, are the investigations documented and can you retrieve that information? Secondly, we wanted to look at outcomes. How many of these patients have good control for blood pressure? How many of these patients develop complications? Data quality. Is this data complete? Do we have a synergy between what's in the facilities and what we see at the KHIS? And in order to do this, we were looking at two sort of systems, one that uses an EMR and one that's paper-based. So our intervention site was Makueni, which was using the electronic system, and the comparison was Nyeri, which was using the paper-based. Next slide. So it was a cross-sectional study where we were looking at records for the past year of patients who attended the hypertensive clinics in Tawa Sub-County Hospital, Makueni County, as well as Karatina, which was in Nyeri. And these are high-volume hypertensive clinics. We did a descriptive analysis for the variables collected and entered by right analysis for those that were significant, as well as did a regression model. For the data quality audits, we were trying to look for completeness and consistency to the national reporting sites. Next slide, please. So from a total of 729 records, 77% were female for both sites. The age group that was mostly reviewed, or the records of that age group, is 60 to 69. We didn't have a big difference in the average blood pressures between the Makueni clinic and the Nyeri clinic. However, we noticed that the Makueni clinic, which was using the EMR, did better in tracking comorbidities. And the regression model also showed support for this. When we're looking at the variables that were tracking investigations, BMI, counseling on complications, the EMR showed that data completeness was much higher. Similarly for the consistency to our KHIS reports. Next slide, please. Further than that, we did actually a difference in difference analysis. So we looked at Makueni, which had the EMR, and tried to see how does the data speak before they had the EMR and after. And it seems like the EMR performs much better in recording investigations, BMI, and counseling. Next slide, please. So in conclusion, we did find that the EMR actually improved care process outcomes. We also were able to see that comorbidity screening is documented much better using the EMR, and we hope we can scale up on this. Next slide. So one of the things that has really intrigued me is how everyone is pulling out their phones to try and record slides. We need to be tech savvy, like Prof has said. So if you want to get a slide deck downloaded, please go on your phone, Google the Medical Learning Hub, search for MOH KMA. That's 2023. Next slide, please. You just fill in your details and it will take you to a portal where you can download my slide. And I think that should help us in terms of leveraging on tech, not just on EMRs. And I see an approving smile from Prof. Santeni sana, good afternoon.
Thank you very much, Dr. Mutiso, for that highlight on EMR use. We all are moving to technology for electronic medical records. And even for CME, MedHub is a very nice place to get your learning material and be able to learn, and also you sharing learning materials within the platform. So our next speaker is Dr. Gordon Yosa. Dr. Yosa is our senior and one very inspirational physician who has kept us on our toes in terms of HIV/AIDS education. From my very young years into medicine, I remember Yosa was always in a conference speaking about HIV/AIDS and has really built our capacity around that. He's a KMA member, KPA member, and a great advocate for HIV care and treatment. I welcome you, Dr. Yosa, to take us through the next session.
Thank you very much, Joy, for the kind introduction. Very good afternoon to you all. I'm on sub-theme 4 of our conference, that is syndemics and emerging NCDs. Syndemics means two medical conditions that may be synergistic in a way or two. On COVID, which it does fortunately come down, and then of course HIV does the dual pandemic. Let's go on the clinical side. My topic is relapse of a febrile illness with the difficulty in breathing, and was of course presumed COVID. This was the time when COVID was its peak, and it's a case report. I have only one disclosure that whatever image I'm showing is just strictly for educational purposes. Patients are very sensitive. It's not for just other use otherwise. Next one. Next. And then, of course, another one is that my mentors left a very clear message. When you present on our patients, and as they mentored me, I must always have a tie on to respect the patient. So allow me to use a tie when I'm presenting this. The pulmonary, that's the lung, remains the most important area or organ for morbidity and mortality in HIV/AIDS. Whether you do clinically imaging or post-mortem, still remains it. Normally it's very good to know what has caused the problem, but often due to cost constraints, not possible. During the COVID era, all of us are aware we've walked the journey. It is very difficult to examine a patient quickly and thoroughly. And not only that, but there is positive information on the triple burden of the disease, TB, COVID, and HIV. The aim of this was to highlight the prognostic value of cardiovascular risk evaluation in COVID-19. All of you who had seen that, we lost a number of patients, sudden death. And then, of course, update practice points in HIV/AIDS and COVID, very dynamic area, and see what is new. And then, of course, this was a period when HIV alone had very few maybe updates compared to NCD. So in methods, the case report, and then, of course, review clinical hospital records between 2018 2022, the COVID era, and a literature search for something relevant and update. This is basically a lady of 75, weight 80, a business lady, born again, who had a children, one is adolescent. Strictly information was kept out of the children, that's inadequate counseling. She helped her husband get treated, but she was always kept out of the consultation room. And the problem was lipodystrophy, an ED. And then, of course, she was kept out, so that's again an area of non-disclosure. We eventually cancelled them. There was a second opinion. The diagnosis was made in 2009. She was told that her CD4 count was high, so it's really part of denial. She was not following it. The husband offered her Tripla. This was taken erratically next. And so she had 2 admissions, end of December, and then of course 3 months afterwards. She had a fever, and of course lost weight, skin rashes. Starting point CD4 count was 26, very, very low indeed. And viral load was over almost 3 million. So we had to work on ART changes. From matricula, Rilpivirine, of course those of you who know Rilpivirine, the beauty, anything above 100,000 on beauty, the single substitution of the efavirenz. But eventually we came into Triamec. We did an OGTT which showed pre-diabetes. You can see the inflammatory markers are very high, 132, 506 CRP. Quantiferon was negative, sputum including again the lung, of course, was negative. The TB screening was optimized, the colitis, UTI, and of course you can almost sense something is amiss. And COVID repeatedly was negative, next one. And then she was readmitted after 4 months with the same fever, this time convulsions, fever, left arm twitching, difficulty in breathing, obviously respiratory distress. And this was at around midnight or 1. The resident did a very good job. And of course, we did a CT scan emergency as the rule is to exclude COVID. And then it shows a cavity, miliary TB, and then pulmonary edema, tachycardia, bronchospasm. And then of course the echo showed ejection fraction at 36, which is low. And HIV, of course, obviously it was poor adherence, as I mentioned before, CD4 count low and viral load very, very high indeed. Pre-diabetes state was very brittle. As soon as we introduced a bit of hypercortisone, the resident 1 AM, you can see the beauty of recording your observations. I just put it deliberately for training purposes. Give 5 minutes, it's brittle, it goes very low. She can easily go low, and you are low at 1 or 2 AM. So that's how we manage to control it. And obviously, very high inflammatory markers and signal danger. The priority was, of course, strong suspicion. They're okay, but we have to exclude cardiac injury because there are a number of patients, sudden death, and we wouldn't know what it is. You can see extremely very high inflammatory marker. Thrombobiliary screen would obviously be indicated. Ejection fraction was repeated, it was 45. Apex is the lead aspect of cardiac suspicious. Cardiac enzyme serial, the ECG serial, suggested cardiac injury. And then, of course, CT scan because of the seizures was normal. For PNP, which is a very good marker for pulmonary edema, was very high. Abdominal pelvic is normal. Emergency pulmonary angiography, I think this is Hakatan, it's not in the rural, this is a slightly privileged position to exclude pulmonary embolism, that was the must. Still, it showed miliary TB, and there were para-aortic nodes. The gold standard for TB is the sputum AFB, but of course this time we had to go on for TB. Admitted again in the ward, and I called in an interventional cardiologist, among the very few in Africa who've been trying for many, many, many years. And of course, he quickly, within the shortest time, this is known as myocardial infarction, pulmonary edema. This is sepsis syndrome. So we have now, you can see the cocktail of drugs pumped into her. Sometimes you don't know which one worked and which didn't work. You can see on the right side how the liver enzymes are very high and reduced down. So you have to know how to adjust them with the time. Next time, yes, ECG, just to show normally it's T, but normally what we want is ST elevation. Miliary TB with a cut of an eye. Here the CT scan, no features of pulmonary embolism, but para-aortic adenopathy review. Yes, thank you. Yes. And then, of course, in discussion, intensive care patients, this is the earliest studies by Professor Huang in New York 2000, about in the era of HIV when it started. You can see respiratory pathology remains the key thing. Cardiac conditions are very low. I did a study in my own hospitals there. I think this was expanded. You can see we lost a number of patients because the critical care was still lung disease. So the lung is really where everything goes. And COVID also went there. Next one. And then, of course, current information, CD4 counts a very good barometer. You can see when it's very low, almost. Bacterial infection is still very important. TB is always there. Mark is there in conditions to, of course, at very low CD4. Higher CD4 slightly different. And excellent work from Kisomo, which suggested that when they looked at, from Kisomo, Warura, I think, when they looked at HIV patients dying in a high prevalence area, they have noticed the cause of death is not what NCDs now. No longer. It's called epidemiological transition. So SCD is high on the rise, communicable disease. So not IRT alone, go to the next one. And then of course critical care, if you see disseminated TB, biliary TB, is a very dreaded complication. Patients normally can't survive. Is NST elevation, is it only here? They did a global study, you can see all the red. The prognosis is worse in African descent. So we didn't have myocardial infarction in the past, but now the data globally is showing that time is muscle. When you've got a patient with heart, we have done statistical work that time is muscle. If you every 8 to 12 admissions, you delay 6 to 8 hours before you get definitive treatment, the patient you lose. So this is now where to say, is there value of doing cardiovascular screening? If you pick the right link, you will have that cocktail, and you always pray which one will help, which one will not work. Next one. And of course, in data analysis, this is a resident from South Africa, Beck and Group. What are the clinical phenotypes? What is driving now the mortality in HIV/AIDS? COVID has opened that door for respiration. And now it is inflammation, high inflammatory markers, and immune activation. That is iris and the like. Our teacher, Aloch, if he's here, is going to talk for 10 hours about the iris. He likes it very much. So conclusion, emphasis is on holistic interprofessional approach. Don't do it alone. Share it up. Get on the phone and talk. In a control HIV infection, with the holistic burden, you must evaluate. This is a dynamic area. We need research, and then the research should be the type where it must translate in clinical care. And of course, those are my mentors now, Dr. Suk there in Award 1, Dr. Kanga, Dr. Cardiologist, Dr. Stuo, Mama Manjarala, I opened the hospital, both hospitals, they are all departed with your colleagues. And there is now Salim, among the most powerful Muslims in Kenya. Very, very simple, handy young man. So they have mentored, and there is somebody down there, you know him, Dr. Roach in Red. I think that was Valentine night, when he was among those who celebrated the dolutegravir. Thank you very much for celebrating the Valentine night, Dr. Roach. Thank you.
Thank you very much, Dr. Yosa, for that very elaborate presentation. I would like to go to our next speaker, one of our senior most doctors, very esteemed. We walk in his shoes, Dr. Joseph Aloch. His KMPDC number 00, who knows? 001. 55 years of service. You can imagine. We all aspire to get there, looking healthy. He needs a clap. Yes, thank you. Thank you so much. He's a past of many. Past chair KMA, past chair KAP, Kenya Association of Physicians. He has been the founder. He's the patron Kenya Association of Prevention of TB and Lung Disease. He's the past Vice President, Commonwealth Medical Association. I'm very proud to be walking in his feet. Current Vice President, Commonwealth Medical Association, and walking in his big shoes. That's pride. Yes, he's an advisor of the EA Royal College of Physicians, Edinburgh, and today, with those 55 years of experience in healthcare, he wants to talk about healthcare quality. Who best to do that? Welcome, Dr. Aloch.
I never know whether somebody's introducing me or making a speech. But I've gone by all the 50 years, and it becomes a household thing. Thank you, President, for this hearing. And Dr. Yosa did a very good presentation. But I just want to remind you now, Atripla is officially discontinued in the use of HIV treatment. I'm sure a lot of your patients are on Atripla. So when you go home tonight, please change them to Triomec. MSCD is not a manufacturer anymore at Atripla. How many of you knew that? At least AMPAP people should know that. So it's officially discontinued. The reasons are medical. I have no conflicts to declare, except that recently I graduated from University of Nairobi with MBA married but available. We talk about quality. Yesterday I did talk about quality of life, and I like quality things. So I'll continue talking about quality of healthcare, the concept of quality of healthcare. Now, what is healthcare? Everybody was talking about healthcare this morning. But basically, I'm sure Professor already talked deep about the life cycle of health. But basically, it's a prevention, treatment, and management of illness. That's all about healthcare. And the preservation of mental and physical well-being, for some people may need it, through the services of the people concerned, call it medical and allied professions. Okay. The important difference between health and healthcare. Okay. All you know how to define health. Healthcare can be traded on the market. But now healthcare is a business, and for those of you who are physicians in our meeting in Kisumu this year, and we talk about healthcare as a business. But medicine is a profession. So healthcare is a business, and anybody can go into healthcare as business. And it can be traded on the market, and it differs from health. You cannot trade your health on the market if you did healthcare quality, which we'll talk about now. And everybody's talking about quality, talking about efficiency in healthcare, but they have no idea what they're talking about. They're using the words like that. Because for you to say, oh, you're improving quality, or becoming more efficient from what to what? You must have the basic lines to measure, okay? So healthcare refers to the amount of value that any healthcare resource provides as evaluated by some metrics. So you must have some metric. It is assessment of whether it's an excellent enough for those people who are enjoying your facilities, okay? Now, quality is a term which is ambiguous, completely meaningless. So all of you can use it any time. You can say this is very good, this is a quality conference, and you get away with it, despite all this less quality aspect. Now, what is the definition of healthcare quality? Meeting the needs and probably exceeding the expectation of those we serve. That is the definition of healthcare quality, and delivering all and the only care the patient and the family needs. And this is important because quality care is the degree to which service of individuals and population increase the likelihood that the desired health outcomes. Yesterday I talked about the quality of life and healthcare outcomes in our community. And this is important. It's a level of value provided by the healthcare resources as determined by some measurement. And again, I repeat, in all these aspects, you must have metrics, what you measure, because you can say good quality, good compared to what? How is this not bad? And like quality in other fields, assessment is something good enough, whether it is suitable for the purpose for which it is was intended. Now, the early definition, as I said yesterday, of quality of life depended, was shaped almost exclusively by health professionals. So the doctors and the healthcare were the ones who said that we're delivering high quality care, depending on our scientific evaluation, how well we are following up the so-called guidelines, evidence-based medicine. They assume that if you're following evidence-based medicine, which it itself now is also becoming doubt whether you need it, and particularly during the COVID, it was impossible to practice evidence-based medicine in the treatment of COVID because you could not do RCTs during those times. So evidence medicine has also becoming, it was only available between 1996. It's up to its purpose for the last 30 years. Now we have to find out other ways of basing our best practices. But if you felt that the best way that you're doing good quality healthcare is your doctor doing a good job, that was fine 30 years ago. But now we find that the increase of good preferences or views of patients, the public, and other key players are relevant. If Professor Rogo gives oncology patient had good medicine for chemotherapy. I've given the best medicine according to practice. But the patient is vomiting and nausea and feeling bad. I said, no, this is the best medicine. So I'm giving you the best quality healthcare. So he's not taking the cognition that view of the patients also matters at the end of the day in what healthcare you're providing. So you just don't give yourself as a player in there. Now the concept involves structure, process, several domains, effectiveness, quality of services by the system, by the individuals there, and related to several outcomes. It means engaging the patient and involving the community as well. And it's a collaborative effort that involves the whole family and the whole community if you talk about healthcare. Quality of health, unfortunately, like all medicine, is evolving as our knowledge is also evolving. Most professionals are developing guidelines for treatment of everything. Professor Wayne is always out developing guidelines for various aspects of prevention. But those guidelines are just guidelines, and they often mean nothing, but they are guidelines. And they say they propose based on evidence-based medicine. Sometimes we wonder whether those really evidence are really working. But now we're getting less and less on evidence-based medicine, and we use it for more our brains and community assessment. So we need standard care drive for guidelines. Obviously, we give you a measure of quality healthcare. When you talk about quality healthcare, the professionals and managers must also get better ideas on what they're doing and what they're providing to the community. I'm not very familiar with this all the time. Now, what are the advantages of quality healthcare? Because high quality has a big impact on patients. It gives them better outcome if you go to good quality, ideally. But the patient will be happy, the recovery time will be improved, the lower risk of complication of mortality, and it's an improved long time. And in these days, everybody goes for accreditation. The quality indicators must be relevant, important, and measurable, and the basis of evidence-based practice. Now, there are several domains. We can't go into each in detail because of time, but the important thing is that our healthcare should be patient-centered. Now, this has been present already in a presentation. What information what reliance we must give to our patient, and it must be safe, effective, equitable, timely, and efficient. In short, all our healthcare provisions should be avoiding harm to the patient, safe, effective, based on the scientific evidence, the best available evidence, and patient-centered, timely, no delays, no harmful delays, efficient, avoiding wastage of equipment, supplies, and in short, affordable. Now, efficient, affordable. If you can provide whatever quality of medicine and healthcare you provide, there must also be cost element, i.e. it must be affordable to the patient. And that is when it is called quality, not just high standards as we call. And of course, it must be equitable from community point of view. And Dr. Rob is very strong on this. It must always be equitable. Somebody already talked about this, the position. So your quality of healthcare is only efficient. It means that you don't do unnecessary tests, which a lot of doctors do. You don't undergo needless imaging tests. It's very good to have all those high-power tests, but they should not be needless. And you don't have prescribed unnecessary antibiotics, which you all want to do. So basically, at the end of the day, half of you do very poor quality healthcare. You may not like it, but it's the truth. You just do 101 X-ray. Somebody comes with a little headache, let's do MRI. Somebody comes with a little chest pain, do a chest X-ray. They don't even use their stethoscope, they've forgotten. And a little sore throat, giving them augmentin. So this is poor healthcare quality, which is what we practice. And of course, you taught the patient also to practice it. So they say, oh, every time I've got a sore throat, I normally go to Dr. X, he gives me this augmentin. And then I want to avoid paying consultation, just give me the augmentin. I think I've got the same symptom. That is very poor community. So these are some of the domains of healthcare which we must look at. And this is the value-based healthcare. As important for the patient, it lowers and better outcomes, and for the providers of healthcare, you have a heart patient with satisfaction, the rates and better care for the efficiency, and those who pay for the treatment, they are happy because you reduce the control and reduce the risk, and for those who supply equipment, you can come with better outcome, and for the society, reduce healthcare spending and outcome. So it's okay having quality healthcare, but it can't stay the same as it was 10 years ago, and 10 years ago, what you're doing yesterday cannot be good today. So you must go to what is quality healthcare. The quality improvement can be defined as combined and seizing efforts of everyone healthcare patient and their family, researchers, payers, planners, educators, to make changes that will lead to better outcome of health, better satisfaction, performance, care, and better professional development for the doctor. That was defined the better. I've not been starting my presentation. So healthcare should be continuous quality improvement using the various strategies. And at the end of the day, it's what is known as quality assurance, so that you continue improving your quality. So in every health institution, department, there should be quality assurance department. And these are the things that are driving the need for quality, continuous quality improvement. That accountability to those who provide the money, eliminate unnecessary treatment procedures, attend medicine and life evaluation in practice, and control medical expenses. And this is some of, if you're doing quality improvement, this is some of the things you need to do and how we modify them. So where do you start? Define the area you want to change, say the aim is study measure, say the changes. How effective is a measure in quality? Is it important? How costly is it to implement? Is it achievable? What preserve costs are produced? Will we want to do it at all? You see, in God we trust, but all others must bring data. So that we do. Okay. See, some of the challenges in healthcare, in many of our organizations, we collect a lot of information, and the competition told you how the electronic health record. But it's very good to collect information, but what do you do with it? You just have a junk of information and keep it there. You must have a system of what you're going to do with that information. Information collected and not analyzed is useless, because it's not improving your outcome. So you have also how to analyze the data and how they're going to do with it. So we need medical science going very fast. So you need a health quality system that well-managed healthcare professional will provide safe, thorough, and hard vigilance. Now, a lot of you now think of accreditation as giving the quality. Now, let's all agree that accreditation is useless. And people say, oh, my institution now are accredited by so. It's pretty useless. It doesn't, as far as providing quality healthcare to the patient, it does not guarantee, it does not mean anything. And it just shows that you are meeting something you said yourself. The patients are not asked that, are you feeling good? When they come to accredit institution, patients are never asked how they feel, what they do, and other workers are not asked. They just see the few things the other than clean this place, put this equipment here, and have this stuff. The purpose of accreditation is to strengthen the organization and improve high quality care. So you must define the quality care you want to do before you talk about you may give a benchmark marking how your organization is doing. But that's okay for some of the industry. And in healthcare, it becomes a bit silly. It's got a good process. Because of time, we cannot say each and each comment. We'll agree that this lecture should have been 1 hour, but they don't need it. Because many people wanted to talk about it. There's a call for a new model of personnel. Healthcare seems to need implementation of evidence-based phase-quality medicine as a system responsibility rather than the sole responsibility of individual clinician. So healthcare quality is not just because of you doctors. I know you come here and want to go and find the best medicine. True, and that's only 1/3 of the fraction of healthcare quality. The other kind of you come from the building, the equipment. We saw some of these by photo excellence. The other third, from what the patient responds. So there's a lot of people who are involved in care. So you must know what you want to accomplish, learn how to do it, and study. The traditional models focus on education, need of care, train. Also, we provide a structure, improvement, and the oversight plan. Now, this one will take victims. We're not able to understand this facility. We started talking about this. Let's forget what we have said so far. So, people of men who are need to know our administration. So even in this class, we even talk about this. So quality is never lacked. It's always the result of high intention, sincere effort, intelligent direction, skillful execution, and it represents the wise choice of many alternatives. And then also you've got many ways things you can do, but the quality will depend on what you choose. Just in case you've been listening, thank you. Actually, I didn't hear them listen. Thank you.
Thank you, Prof. Dr. Anuj, for that awesome presentation in terms of quality. We endeavor to improve as we move on. I know your blood sugars are getting low. True or false? If you don't speak, we continue till the cows come home. Blood sugar is getting low. Mine is. But we want to hear about the cars. That will only take around 10 minutes to the least 8 minutes, isn't it? We've got Crispus Nyenze, who's the branch manager, CFO Mombasa. We look forward to hearing more about the cars. We give you 10 minutes, then we will break out for lunch. We will come back here for a plenary and have agreed that we will break out into 2 rooms for the speakers that remain. We'll have some partner engagements in the plenary, and then we will ensure that the rest of the speakers for the afternoon will know their allotted room. So welcome, Crispus.
Good afternoon. My name is Crispus Nyenze, branch manager for CFO Motors, Mombasa. I think by right now you've got news that Toyota and DTW have merged together, and we are one big family with more products, more brands, and with a customer proposition. It's a house with everything, anything to do with it. So CFO stands for, it's a French company in fact, and it stands for Confederation for Africa and Overseas. It's very big in West Africa, so it has come into East Africa, where it has acquired a few companies. Next slide. Okay, I'll be explaining about our company, why CFO Motors. I'll also explain about the Suzuki product lineup, VW product lineup, Mercedes-Benz product lineup, commercial products, after-sales support, and Topo assembly next. So CFO is home to both passenger vehicles and commercial vehicles. On the passenger side, we have brands like Suzuki, Volkswagen, Mercedes-Benz, and Toyota. On the commercial side, we have brands like Mercedes-Benz trucks and buses, Hino trucks and buses. Then we have Sino trucks and Hyundai trucks. If you look at all those products, it's like we have covered every section in the world, from German to Japanese to Chinese. So we have everything you may need. Next, when you buy a brand new vehicle, that vehicle comes with a warranty. The average warranty is 3 years, between 3 and 5 years. And the reason of having a warranty is to have peace of mind. A zero mileage vehicle will serve you for 5 good years, and the only thing you'll be doing is service, loop service. Your work is just to drive, get to work, back, go to the shamba, and all that. Reliability. Zero mileage vehicles, you can attest with me that they are more reliable than in Kenya we call them the ex-Japan. Because an ex-Japan vehicle will be around 8 years old by the time you receive it. This one you have to start from scratch. After sales support, CFL Motors have more than 36 branches and dealers across the country. So wherever you are in Kenya, you're covered. From Lodwar to Kisumu to Mombasa, Nairobi, Nanyuki, Isiolo, all those places, you're covered. These vehicles which you're selling are locally assembled. In fact, in my range of vehicles, there are only 2 products which come as FBO. That is the Suzuki and the Mercedes-Benz passenger cars. Everything else is assembled in Kenya, from the trucks, VW, Mercedes-Benz, which are at Thika. The Hino and the Toyotas are done in Mombasa at FBO. Next. Suzuki product lineup. We have the Desire, which I have outside there, the Ciaz, which I have outside there. I don't have the Boleno, and the Super Carry, the Jimny, and the Tigger, but I have the XL6, the Desire, Ciaz, and Boleno, and I have only the Desire, Ciaz, and the Boleno. On the Volkswagen lineup, I have the Polo, the Tiguan, and the Touareg. These vehicles have a range of engine capacity between 1.2 liters and 3 liters. 3 liters being the Touareg, the Polo Vivo being 1.6 liters, the Desire being 1.2 liters, which are very economical on fuel and very comfortable. Next. On the Mercedes-Benz product lineup, I have the GLC, the SUV, GLS, GLE, and E-Class. The market dynamics these days are basically going to the crossover segment. If you look at the GLE, that's a crossover of the E-Class. The GLS is a crossover of the S-Class. So you get the comfortability of an S-Class, but a little bit higher from the ground. On the commercial group, I have the Inotrucks and buses. These, especially on your profession, you can make a very good clinic, mobile clinic. The Sinotrucks, these are for prime movers and the Mercedes-Benz. The buses, this one are good for the mobility of patients. And then the Hyundai trucks, we have the refrigerated ones, which can basically work very well for transporting medicine. We also have tradings. We have one department in our group called Automac, where you can bring your old vehicle. We do a valuation, we top up, then you walk away with a brand new vehicle. It's situated in South Sea in Nairobi. Next. So, on after sales, anything we sell, we usually offer an after sale service. This is basically to give you a peace of mind. And as I told you, we are covered all around Kenya, from Lodwar to Kisumu, Nairobi to Mombasa. And the vehicles, most of our vehicles are localized. This means that they have been tuned for the African market. And that's why we are doing the local assembly. It is an advantage to us and an advantage to you, because also the company is enjoying the tax exempts, because it's built Kenya, buy Kenya, build Kenya. So this is how the vehicles come in containers. Then we assemble them in Thika. This is SKD form. We also have the CKD form. CKD is completely knocked down. We have some offers for you. So the XL6, we have an offer. If you buy an XL6, you get 25,000 worth of fuel. as customer advantage to you. Then we also have some understanding with several banks whereby you can get 100% support from the bank with monthly payments. Next. So we have a special offer for the Desire too. When you buy a Desire, you can get 5,000 worth of fuel. And sorry, I did not mention the price range. We have vehicles for as little as 2.1 million. That is the basic which we have, and as much as $94,000. $94,000 right now is around 11.5 to 12 million. And next. So I think I'm much better than the 10 minutes. And for question and answers, I have my team outside there, which will be able to answer all the questions which you'll be able to answer. And just to answer one question my friend asked about the turbocharged and the naturally aspirated. I only have one vehicle which has a turbocharger. The rest are naturally aspirated, and it is up to Euro 4 standards. Thank you.
Thank you very much, CFAO Motors, for that presentation. We will engage with you in your stand and get to know more. It's lunchtime. We need to say hooray that it's lunchtime. We need to get out and nourish and get to network, get to see each other, talk to each other for a few minutes. But before that, we have the following persons: Kevin Figa, Benedict Muma, Alex Munyasi, and Nelson Mandela. Kindly see Peter at the ICT desk there, so that we see, we get your presentations for the afternoon. We know we have 2 presentations which were to be done. The following speakers, Dr. Sarah and Esther Achar, we kindly request, we are moving your presentations to the afternoon after we've had lunch. We will convene here at the plenary session, and we'll begin with the 2 that have hung on. Then I will be able to tell modalities for the other 2. We are looking for a room to ensure we break out and be able to run the 2 so that we get out and celebrate. Today we are celebrating 100 years of EMJ. And to be able to celebrate, we need time to have some fun. But I thank all of you for having stood steadfast, listened to the sessions. I know we will engage further as we ask questions to the presenters. Find them at lunchtime, ask your queries. We'll have probably a session in the afternoon that we can be able to ask further questions. And we apologize for the time. It's been really slow today, but we hope that we'll catch up at the end of the day. Thank you, and enjoy your lunch. But remember to register for dinner. It's free. There is no one being charged, but we want to ascertain that people will be able to attend. So lunch is served down at the restaurant. Your tickets can be picked as you exit for lunch. Thank you.